Hi, this is Brian Kim. I'm going to share with you this case of a patient with a secluded and fibrotic pupil, and I'm going to do a two-handed pupil membrane peel technique. This patient also has a cataract, and I'll use iris hooks as well. And you'll be able to see lens disassembly using double chop, cross chop, mechanical fracturing techniques, and the use of the iris hooks. And like I said, the two-handed pupil membrane technique using micro forceps and instruments to very carefully peel off this membrane. See, the problem with membranes is when you're peeling them, you might pull on the iris root if you do a one-handed technique. By doing it this way, you help to minimize any trauma to the iris root by doing the two-handed maneuver. So I'm steadying the eye with a cotton tip and then using a corneal marker, which will help me to center and size the rhexis. These are my paracentesis incisions using the diamond blade. I'm making those incisions for the cataract surgery as well as for the iris hook placement. So I like to place 5 iris hooks, 4 around the edges and 1 subincisionally, and that is so that I have excellent control. You saw the patient suddenly moved when I was making that incision, so luckily I wasn't in the eye at that time. So I continued to hold the eye steady and make my incisions as efficiently as I can before the patient moves again. Oh, and the patient moved one more time there. I'm going to place another scleral incision in the subincisional area for my main incision, because when you're doing cataract surgery through the main incision, you don't want iris prolapse, and retracting that iris in the subincisional space with a scleral incision is really nice using the iris hook. So this is intracameral lidocaine and then intracameral epinephrine. You can see that the pupil is stuck down to the anterior capsule. And this is some dispersive viscoelastic. And as you can tell, there's no viscodilation with this maneuver. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me, and then I enter. And you can see there that that main incision is right over that scleral stab incision. So I'm using the Haldi-Perkar capsule rhexis forceps to grab the pupillary membrane, and I'm just trying to find an edge that I can start peeling. I'm using the cannula to kind of help tease off an edge there. That didn't quite work, so I'm going to use a Sinskey hook, which will hopefully provide a little bit of counterforce as I do this. So I grab with the rhexis forceps, and then I'm teasing off the membrane from the pupil edge with the Sinskey. So I got a nice little opening now. But as I'm pulling, I'm noticing that I am putting quite a bit of traction on the iris root. So rather than traumatizing the iris root, I'm still holding it with the rhexis forceps, inject some viscoelastic, and with some micro forceps, I'm going to grab the pupil and keeping it stationary, and then I peel with my right hand with the rhexis forceps. And I'm grabbing little by little along the peeling edge with my left hand, and then with my right hand, I'm applying some countertraction to peel off that fibrotic membrane off the pupillary edge. That worked really so well using a two-handed technique, pulling the pupillary membrane off with the rhexis forceps, but then using microforceps for countertraction so it doesn't stretch or traumatize the iris root. So that minimizes any stress on the iris with that two-handed maneuver. So this patient's wanting to turn their eye to the right, so I'm placing some angled McPherson's through the main incision and using that indirectly to hold the eye straight, which allows me to place that iris hook through the scleral incision. You rotate the stopper so that the hook faces down, and then you can hook it around the iris. So the more complex surgeries you do, the more use of the iris hooks you have, the more confident, more comfortable you get, and it doesn't really take that much time. For those who don't have any experience with this, you might use rings and stuff, which is fine, but you know, iris hooks are really much more versatile for much more complex situations. With dislocated lenses, sometimes you have small pupils. You really need to use iris hooks in that situation. You don't want the ring to fall into the vitreous space. And so, again, a variety of situations where you can use iris hooks, much more versatile. Sometimes you just need a sector of retraction, and so you don't have to retract the entire pupil, just maybe a certain quadrant. And so that's why I like to use the iris hooks, and you can see it was fairly efficiently placed by placing it and then twirling the stopper, pointing it down, and then grabbing the iris hook to hook it, and then cinching down the stopper. So I'm pushing some more viscoelastic in, and then I'm using the Haldey-Perkar forceps to puncture. Grabbing the right side of the tear for the rhexis. So I have to go around circumferentially. Again, with these forceps, exquisite control, wide opening of the teeth, very easy to grab the rhexis edge. The low profile reduces viscoelastic egress and minimal radialization forces during the rhexis. So finish off the rhexis. And this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, point the tip back up. Rotating the lens on the right side, and you can see the lens spins nicely there. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off, minimizing Decimase trauma, removing the surface epinuclear material, placing the chopper underneath the rhexis edge contra-incisionally. But before I do that, I come out and then just remove that tiny little bubble that was there. Must have been bothering me. So I place the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, bringing the instruments together, and it bisects the lens in half, again using horizontal forces, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, fracturing the right heminucleus in half, and that is cross chop. Using some vacuum to lift that first quadrant up, crushing the lens between the instruments, and then emulsifying the lens pieces. Using the chopper to pull up that second quadrant, and then emulsify the lens. Rotating the second heminucleus in front of me, placing the chopper around the lens, pulling it centered toward the phaco tip, and then fracturing the lens in half. Using some vacuum to grab that third quadrant and then crushing it between the instruments and emulsifying it. Placing the chopper around the fourth quadrant, hooking it up, getting around the lens, crushing it between the instruments and emulsifying the lens piece. Grabbing the anterior edge of the epinucleus, which begins to tumble out, keeping the chopper deep in the bag. You always have to be careful when you're pulling out the epinucleus to make sure it's not attached to the posterior capsule. So that's why I always keep that chopper deep in case the posterior capsule wants to come up. So now all the epinucleus is out. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye and a handpiece. Start sub-incisionally, removing the cortex from anterior to posterior. With these small pupils and with iritis history, you always want to be mindful of zonulopathy. When you have history of uveitis, that tends to cause zonulopathy as well. I'm being mindful of that, going around gingerly with the INA. I'm not going too high with the vacuum during cortex removal. Switch to polish mode, polishing under the rexus edge of the lens epithelial cells. I do have some fine cortical wisps, that stringy lens material, so I'll have to go around and just very carefully polish. Using the polish mode is really nice and safe. I'm able to get into the capsule fornix confidently without worrying of damaging the bag or the zonules. But because of the wisp, I have to spend a little bit of time there. Go ahead and pulse the subincisional capsular fornix with some BSS, which looks pretty clean. Filling the bag with some cohesive viscoelastic. And then this is the sweep. Again, this is the original sweep. Polishing on the left side first of the lens epithelial cells. And using the sweeper just gives you better access to the subincisional space. And then sweeping on the right side here. And the other reason I like the iris hook is you can titrate the amount of tension. So you don't have to really stretch it too much and cause any damage to the iris. You can just modulate that yourself based on your discretion. Go ahead and inject a single piece acrylic lens into the capsular bag, making sure the leading edge is in the bag. I'm using the sweep to reposition and make sure the haptics are within the bag here as it unfolds. Because I'm not going to go straight to IA, I'm going to remove the hooks now. So go ahead and use angled McPherson's, grabbing the hook on the distal side of the stopper, retracting the stopper with the other hand, and then disengaging the hook from the pupil, twirling it if possible. I'm trying to be very delicate with the hooks because they are reusable. If you yank it, you can actually damage the hook and it won't stay in that U-shaped configuration. It'll turn more into like a J shape. And so you see I'm kind of trying to figure out what to do here. But more recently, I've figured out that this is what you have to do. You have to rotate it 90 degrees and then it comes right out. So that's the best way to salvage your iris hook, is while you're pulling it out. Pull and then rotate it 90 degrees, and then by doing it that way, it comes out much more easily. This last one, you'll see I'm able to do it, not intentionally, but it's able to kind of twirl. It just kind of naturally wanted to turn that way. So I'm pulling, and then whoop, it rotated. And that's how you want to do it. That's right. 90 degrees, and then it comes out. Go in with the INA handpiece, activate irrigation once I'm in, getting underneath the optic, tilting it, and removing all the viscoelastic from within the bag. Switching to polish mode, polishing underneath the rexus edge. Switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a secluded pupil. You saw how I grabbed the edge of the fibrotic membrane on the pupil with my capsulorhexis forceps. I tried to pull it with one hand, it wouldn't come. I tried to use a cannula as counterforce, didn't quite work. Use a Sinskey, I was able to actually create separation from the pupil in the fibrosis. But as I was pulling, I didn't really have good control with the Sinskey, and so I switched to microforceps, 23 gauge microforceps, and I used those forceps in my left hand to hold the pupil as I started pulling with my rexus forceps in my right hand. By doing it that way, it very carefully and easily peeled off that fibrotic membrane off the pupil. I went around circumferentially doing this, and again, I minimized any trauma to the iris root doing it this way, and I feel like that was the most controlled and safe way to remove that secluded pupillary membrane. You saw double chop, cross chop, mechanical fracturing techniques. This lens wasn't overly dense, and so I was able to remove the lens fairly easily using reduced ultrasonic energy, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.